Everyone. I'd like to call the meeting of TCB, our December monthly meeting, to order. The time is 2:04. And I'll just say briefly, we're thrilled to close out the year with a presentation from some of the other tri-chairs that have been doing work in children's behavioral health planning and implementation today. We'll also give a little bit of an update on where we are briefly with the recommendations. There'll be no votes this time. We're still iterating on those, and those will be up for a vote in January. But we did want to talk through some of the progress that's been made. And with that, I'll turn it to my tri-chairs if they want to say any opening comments.
Hi, happy December, and we're almost at the end of the year and a lot of good work that's been done. I'm looking forward to hearing our presentations today and also sharing with you an interesting model that I learned of recently on the Stanford Youth Mental Health Alliance. So I'm looking forward to that presentation as it brings together all the community providers in the service of our youth and their mental health. So thank you all for being here, and thank you for everyone who's online.
And I would just like to say good afternoon and thank you all for being here and taking the time out of your schedule. And I cannot believe it's December already. But I look forward to these presentations today. So no further ado, Erica, I'll turn it over to you.
Thank you. And we're just going to go right into it. We do have one administrative task to do, and that is the acceptance of the November TCB meeting minutes. And if we can call for an order for acceptance of the TCB November meeting minutes. Okay. Yeah. First, second.
I'll second.
Thank you. Any adjustments, amendments, revisions to the meeting minutes for November? Okay, seeing none, can I please have a vote of acceptance of the minutes?
Aye.
Okay. All right, the minutes are accepted. Thank you so much. And I won't hold us back anymore. We'll very excited today to have a presentation from the tri-chairs of the Children's Behavioral Health Plan Implementation Advisory Board, as they have just recently in November released their annual report, which was attached to your materials. If you did not receive it, please let us know, but that was attached to your materials along with the presentation. And I would like to give the floor to the tri-chairs, Elizabeth Canada, Ann Smith, and Carl Chisel.
Thank you. Good afternoon, and thank you for the opportunity to present our annual report. Excuse me, I'm going to adjust myself a little bit. Are you able to hear me okay sitting from? Okay, great. Thank you. Thank you for the opportunity to present our annual report. We've been really looking to coordinate the work across the different advisory bodies. The Connecticut Children's Behavioral Health Plan that our Implementation Advisory Board represents is the advisory board that's implementing a plan for children's behavioral health that was developed as a consequence of the tragedy at Sandy Hook. A process to look at our children's behavioral health system at that point led to multiple listening sessions, feedback from hundreds of stakeholders representing providers, critical system stakeholders, and very importantly, families, to identify what was working about the children's behavioral health system, what was good about it, what were areas for improvement, and what else did we need in the children's behavioral health system. And that resulted in a blueprint for children's behavioral health in 2014. In 2015, the launching of the Connecticut Children's Behavioral Health Plan Implementation Advisory Board. And that is what the three of us represent as tri-chairs. And you can see in, if you could move it to the next slide, you can see on the right-hand side, all of the legislatively appointed representation to the advisory board. And our task is really to look at the 7 thematic areas of children's behavioral health, to look at how we continue to move the work forward to improve the system. The membership, you can see, reflects really the broad composition of who contributes, what systems and what stakeholders contribute to the children's behavioral health system. Next slide, please. Each year since 2015, we submit an annual report to the legislature, and we've given you a timeline that I don't think you can probably read on your screen so easily. But if you go to Plan for Children, you can see each annual report. And what we've provided you here is a timeline that has the recommendations that have been made each year for what will move the work of that blueprint for children's behavioral health forward, because it continues to be a blueprint that really captures the range of driving principles and specific areas of practice that are important to an optimal system of children's behavioral health. Each year we submit recommendations. You also will see on that timeline some of the products that have been a result of the children's behavioral health system. So I'll draw your attention, for example, to pulling together good screening instruments for children's behavioral health, the fiscal mapping work that was done to provide a template for fiscal mapping for the children's behavioral health system and its complexity. And most recently, the report that was done by the Child Health and Development Institute to look at the workforce crisis in Connecticut now. But you can get more details about all of those content areas on the timeline from our annual reports. Today, we're here really to talk to you about the 3 recommendations that we made in the most recent report that was submitted at the end of October. And those 3 recommendations are actually the same recommendations that we made last year in the 2023 report, because these remain the areas that we think are most critical to continue to work to enhance our children's behavioral health system. The first of those recommendations that I'm going to talk about, and it's certainly one that I know that you have heard in most of the presentations that you have had to this advisory body, is that, to the TCB, is that we have a workforce crisis in Connecticut right now. And what I have said to many of you before, and what we continue to talk about, and I've heard in the presentations to your work group, is that Connecticut has had, when we did the Children's Behavioral Health Plan listening sessions to develop the plan, the feedback was we had a lot of things that were really working well. There were areas for improvement, but there was a lot that we were really proud of. And part of what I think you're hearing, and certainly what we are hearing, is that some of what we are proud of in Connecticut is really at risk of disintegrating because of the workforce crisis. And so the challenges that you hear and some of the particular strategies that have been implemented, for example, the urgent care centers, has been related to waiting lists and difficulty accessing services at every level of care that you're hearing about. And if we have less behavioral health specialists entering the field, that means there are waiting lists, that means there are higher caseloads, that means we lose clinicians that are skilled to other lines of work or to other settings. And so this is resulting in deterioration of some of the things that were a strength, some of the services and variety of offerings that we were working to build upon. So the work that has been done by the advisory board and in partnership with the Child Health and Development Institute is that there is a report that was issued in 2023, a strategic plan for the workforce strategies. And one of the recommendations that we will be prioritizing in our work ahead is emphasizing to the legislature, certainly we hope to partner with you in this messaging, is that we need to look at the workforce crisis in terms of the fiscal note tied to that. You have heard that, some very powerful presentations to this work group by some of your members as well, that the cost of delivering services is not reimbursed through grant funding, through Medicaid reimbursement, and through commercial insurance. And so this is part of what is creating a discrepancy in Connecticut in terms of what the pay scales are, and we have less people entering the field. That's one aspect of the workforce crisis that we think needs attention. The other area is to make sure that we continue to build upon the partnerships with higher ed, with opportunities to really encourage providers entering the workforce to enter the workforce in the areas that we've identified as important areas of practice, because this is where we have research supported interventions that work for families. This is also where we can continue to build the work specifically for the needs that are identified through all of the work that we do. So we will be really emphasizing the importance of reimbursement mechanisms to make sure that we can to attract and retain a workforce. The other area that we will be doing additional work group activity is to look at how we expand the workforce for working with children and families to have peer support. This would include peer support, both recovery support specialists with lived experience, families with lived experience to enter the workforce, to have reimbursement mechanisms so that this can be a paid workforce as one way to continue to expand capacity to serve children's behavioral health needs. I'll pass it to you, Carl.
Thank you, Dr. Kanata. Good afternoon, everyone. I'm Carl Schissel. I'm Senior Director of Regulatory Advocacy at the Connecticut Hospital Association. I am also one of the original tri-chairs. Ann, Elizabeth, and I have been the original and only tri-chairs of this advisory board since its inception in 2015. So I think we'll be celebrating our decade anniversary next year. This work is essential, to the quality of life in our state. And so we're grateful for the existence of all of the advisory bodies and all of the attention being paid to this issue. But I think one of the themes you'll hear about, particularly later on when Ann presents, is the need to align and coordinate our efforts. So in part, we're here to talk to you about what the advisory board that we tri-chair came up with in terms of our recommendations for 2024. But as you listen to those, what I'm inviting you to do is think about the priorities of the TCB. And I want to try to achieve an effective and efficient outcome. And the last thing I want as an advisory board tri-chair is to be redundant or miss an opportunity to be effective. The good news about all these advisory bodies is it creates a pretty large chorus. And if we can sing in harmony, maybe our voices will rise above all the other demands for limited state resources. And I am grateful that this particular commission is operating under the auspices of the Appropriations Committee, because, as a former legislator, I can tell you at the end of the day, the buck typically stops there. So this is a great place to focus our attention, and we're really pleased to have an opportunity to assist. So the behavioral health workforce is clearly a top priority and has been for the past several years, and we applaud the efforts that have been made to address the needs to date, but we think more needs to be done there. Since the inception of the advisory board, we've sought to try to identify optimal funding paradigms. Those are three really terrific words. I'm not even sure myself exactly what they mean, but here's what it means. How do we pay for this stuff, right? And one of the ways you can figure out how best to use the limited resources you have is to know where you're spending the money now and on who you're spending the money now. And, I'm just an old man trying to make sense of the world, right? So, for me, figuring out how current appropriations or borrowing or whatever is being spent, what federal money's coming in, what local governments are doing to get money, all that stuff lends itself to funding the system and the services we all need. And so back in 2000, I think it was 2018, yeah, the slide says, we engaged Carillon, then known as Beacon Health Options, the state's administrative services organization, under contract with DSS, DCF, and DEMIS, I believe, to develop a fiscal map of children's behavioral health services. And the reason we wanted to do that was to try to get at those basic questions that I just raised. But according to the report, and I think this is a laudable goal, the goal of the financial map is to provide a visual display of the expenditures dedicated to the existing behavioral health continuum of services and supports available to children and youth in Connecticut. This integrated fiscal map allows the state to think strategically about the overall system and roles each agency plays in service provision. We also intended the map to identify gaps and inefficiencies in the system, our goal being to increase coordination among the agencies, but also identify opportunities to do stuff like braided funding or, whatever creative theory is sort of the flavor of the month. But ideally, if we could prove to governors and legislators that whatever money they give to the system is going to be used in an effective and efficient way to fill gaps and meet needs, then we have a better chance of getting more commitments to meet future needs. And so that's kind of what we're talking about generally when we talk about optimal funding paradigms. And so recommendation 2 in our advisory board report is to figure out a way, and I'm not going to say redo, but basically that 2020 fiscal map, which is actually encapsulated in this document, which is 87 pages long and full of graphs and surveys. And thanks again to Caroline for putting that together. I think it might be worth exploring the opportunity to do a new or updated fiscal map. I'm sure things have changed since state fiscal year 2018. And so that's the idea that we're recommending as an advisory board, that we dedicate our attention to updating the fiscal map for all the reasons I just recited. And that's our recommendation number 2. So on that note, I'm going to turn the floor over to my tri-chair, Ann Smith, to talk about our third and final recommendation. Ann?
Thank you. Thank you, Carl, and thank you to TCB Tri-Chairs for having us here. So we talk about the children's behavioral health system. I would like to call your attention to a beautiful diagram that you have in your packet, which begs the question of whether we have a system or do we have systems. And the truth is that when you take a look at all of the advisory bodies, and you take a look, we had fun pulling this together because you had to take a look at how different the representation is here. So we know that we have some advisory boards that are housed in specific state agencies. We know that we have some that are state agency bodies that are comprise family members, providers, and others who are not state agency members. But we look at this and what we see is that there are a lot of different components to our children's behavioral health system. And bringing them all together is the challenge that faces us. We have a very complex system. When we came up with the Children's Behavioral Health Plan, it was informed by a broad-based effort to have input from many different stakeholders. And I do want to applaud TCB for going in that same direction. I would also like to encourage TCB to broaden the scope of their outreach and their seeking of input so that we can ensure that it is picking up input from families, from youth, from community providers. We have heard from a lot of providers, but I would offer that in those instances where established providers, the ones that are generally funded through the state and get recognized, when they're not able to meet the needs of certain portions of our children's behavioral systems, those families, there are neighborhood and community-based organizations that step in to serve them. We need to be making sure that we are getting input and cooperation and collaboration from them as well. So I would encourage TCB to look at broadening the scope of the organizations, communities, and entities from which they are gathering input. And at the same time, when we're looking at what we already have, we have an opportunity and we have a need. The need is for better alignment of all of these state agencies that comprise our children's behavioral health system. And it is an opportunity for partnership as well. Yes, there's the opportunity to leverage the different funding streams. And yes, I am well aware that mentioning the word funding is is something that maybe I want to try to avoid, but we can't. Because when we think about the progress that the system has made, and when we think about those areas in which some of the goals of the system remain to be met, as well as the fact that the goals as they were originally designed are still valid. However, look, we came off of a pandemic. Nobody anticipated that. Okay? We're looking at issues across education, across mental health, across juvenile justice. I can't name them all because I would have to hit every single one of these agencies, and I haven't memorized all of those yet. And when we look at that, it's evolved. It's not as if the system was static. It has changed, and it needs to change in order to respond to the needs of our children and families. So it is an opportunity for us to take a look at what we have and take a look at what is working, but also to take a look at what is it that our families need. And they can tell us. They know what their needs are. There's also the issue of the workforce, which everyone has mentioned already on our team, and which you are all very well aware of. You know, when I talk about families as being a key part of our system, I want to make sure that we get to include them when we're looking at what our system looks like. And as we are looking at solutions to our workforce challenges, let's make sure that we're taking a look at the opportunity for peer support specialists and family support specialists or community health workers. Let's make sure that we're taking a look at how they can help to support the professionals, the clinicians, and all of those individuals in providing services to our families. How can the families with lived experience become more of a support and partner in providing services to our families? And so when I'm thinking about opportunity, I think about what is the opportunity before us today. We have, as my colleague Carl has said, been doing this work for several years. And in all of that time, we've been working in the context of the executive branch almost exclusively. And so the opportunity that's presented to us today is that we now have beside us the legislature. Okay, we have this legislatively mandated body, TCB. So the opportunity before us is for us to work together to improve on how our children's behavioral systems serve our families. And TCB, we want you to know that the Children's Behavioral Health Plan is here, willing to support in every way that we can. But the other urgency is we really don't have the time to start over. And so we can help to provide a foundation from which to launch and support the work that you are doing. We offer ourselves and our work in that capacity and look forward to taking advantage of that opportunity that we have. Our families are counting on us to take advantage of every opportunity before us. We are here to help address the workforce issues. We know that we are facing financial challenges. If we thought that we were financially challenged before, we know that we will be even more so in the coming months. And so it is incumbent on all of us who are committed to improving the children's behavioral health system to look for opportunities where we can build on what we already have. One of the areas that we have identified in this year's recommendations was to seek better alignment between those advisory bodies that are under certain state agencies. And so in that regard, we have actually scheduled a joint meeting with two of these agencies. So we're going to be meeting in January with the Children's Behavioral Health Advisory Committee. We've already had a couple of other advisory bodies come to our implementation advisory board we're excited because the conversation between them is very much aligned with, hey, we all need to pitch in, we all need to work together to make the improvements that our family and children's need. So with that, I would just offer to TCB the assistance in any way that the Children's Behavioral Health Plan Implementation Advisory Board can help to leverage the work that you're doing. We're here to give you a firm foundation in any way that we can. And we're excited to have the TCB working with us in the same direction. And that would be my hope, that we don't squander this opportunity for us to work together to improve the children's behavioral health system in Connecticut for all children. Thank you.
I'd just like to really thank you for your presentation and really for all of your hard work. You've been at this clearly for some time now, and we really appreciate all that you've done, your dedication to it, and the broad amount of effort that you've put into this and being collaborative. And that's certainly what we wish to do here. I think the goal is very similar. Some of the areas in which we do things around legislation and being able to pull it in through a policy perspective is something that we are able to do with TCB. But the areas that you've identified certainly is where we all recognize the workforce issues are huge, and they can't be understated. And when these bodies can work together, as you're saying, and sing and with one voice, it gets louder and louder. I think it's something that certainly will benefit the cause, because it is a tremendous issue. And looking at that peer support model is something we're going to have to do. We need to find creative ways that are also effective. And I don't remember, maybe a little over a year ago, I was at a Medicaid conference, and I learned from so many other states. I remember Florida really standing out, how much they use that as a resource. And I said, this is something we really need to look into. And I think this is something where we can certainly put our heads together. And I'd like to see what we can do creatively, but it's also really effective, because there's nothing like lived experience and bringing that in. And again, I so appreciate the family voice and that partnership. And that is certainly a part of what we want to include here with our committee. And we are having those voices and some lived experience really when helping to shape the legislation. And the other thing I wanted to mention is looking at ways to, there is a lot of overlap, and I think we can sit and look together at what you've done, what everyone is doing, and really kind of look at what we want to most achieve and how to best work together. And so there may not be so many bodies, not just for us, but for all these agencies that are being asked to send someone to these. And that is a great deal of time and energy on their part. So that is just what I want to say as far as initial conversation. But thank you so much for your hard work, and we look forward to continuing to collaborate. And I just really appreciate your presence today.
Thank you so much. The presentation was excellent. And to build on what you said about, every opportunity, as a municipal person and in the number 4 most distressed municipality, we're looking for every opportunity. And a great partner for us has been the Department of Housing, because you can't have mental health if you don't have safe, affordable housing. And leveraging those resources as well. I know that they might not be on the advisory committee list, but I think it's really worth the conversation with them. And Carl, to your point about efficiency, that's what we do every single day. It has to be effective and efficient. And putting all that money together is really important. And then, of course, the peer navigators, which we've used in our opioid model and now in our disconnected youth. Having a peer navigator has been critical to engaging people. But again, the housing suggestion is just what I put out there.
Thank you. Thank you. Any other comments or questions? Oh, Claudia?
Yep. Thanks for coming here today and sharing some of the background of all the work that you guys have done over the past number of years, and encouraging to see on a broad conceptual level some alignment between the recommendations that have been coming forward from TCB and the work that you guys have produced in your plan. Um, I'd like to engage you in your thoughts on how do we help all those advisory groups that currently exist lean into their differentiating factor? And I think of that as something that came up very intentionally when we created TCB and as part of the 5001 negotiations is not wanting to sunset all of those separate bodies because in some way they had a sliver that was different. So how do we get those boards to refocus on that piece that they're subject matter and uniquely owning that information space? For example, BPOC very much focused and grounded in the Medicaid space. Very important that that's a major player and needs to be focused there. There are others. You, as with your collaborative partnership with DCF, seeing a lot of the implementation of plans and seeing the executive branch function, I think is a unique differentiating. It almost seems like a step back and asking each group to identify what's the ask and offer that they bring to the conversation. Because I do think there's some difference there. And if we could slim down and focus on that unique differentiating factor that each group brings, we'll have a more robust way to actually collaborate so that we're building on a conversation, not competing and creating noise in an echo chamber. So I don't know if you have any initial thoughts, but welcome that conversation moving forward.
Thank you, Secretary. You know, I make the analogy to a party. Somebody has to host it. Everybody wants to come. So what I was hoping, and I think maybe, Ann, you made the point, one of the unique aspects of the TCB is the, its breadth and scope. It has executive branch representation, formidable legislative representation, formidable executive branch representation. It's also the newest issue. I know you have a statute and you got to do what the statute tells you, but then there's the real world where we actually try to work together around the rules that are set in law. If there were an organizing entity, and I haven't talked to the tri-chairs, but absent the TCB, in the past year, we've tried to be an alignment agent, an agent for alignment, and engaged in meetings with the tri-chairs of the various groups and also full meetings with the various groups to identify commonalities and at the same time figure out what makes each unique, which I acknowledge your point absolutely. So we can continue to do that, to be an agent for alignment, and our appearance before you today is an example of that, and you're always welcome to come to our meetings and talk to our members as well. But I think a little intentionality around that among the chairs of these various entities would be great. I'd be 100% behind it, either as a member of the team or as a leader of the team. Here's another example, the fiscal mapping recommendation. If there was another board out there that was engaging in similar activity, this would be an opportunity for us to hear it and know about it. Because absent, an instruction or a recommendation not to proceed, I think as tri-chairs on behalf of our advisory board, one of our next steps would be to contact Carolyn and try to sort of price out and also detect among the three agencies who engage that ASO, whether there's a will and a budget to try to figure out a way to update that fiscal map. Now, we might hit the wall, utterly, because it might not be in the Carolyn budget, but the conversation has to happen. And, if we're the ones engaged in that conversation, it would be us talking to the representatives on our advisory board from those three agencies and say, okay, you all voted for this recommendation. How are we going to make it happen? And it would be good for us to know as we do that, that we're not stepping into some, dangerous area or some area where, another entity is intending to do similar work. So Elizabeth, I'm sure you have, and Ann, maybe you have things to add.
Yeah, so to the point that you're making, and I would add to it, one of the things we tried to capture in the diagram of the complexity of the system is there are two bodies that really represent behavioral health for all of Connecticut's children. And that is your board and our advisory body as having that representation across the age span and for all of the different needs. but different roles that each of us have. And then we tried to capture the different advisory bodies and the different departments that have one aspect. So Office of Early Childhood would be looking at the younger children, children who are involved with the juvenile justice system, children who have Medicaid. One of the things that when we did the fiscal mapping, because of the representation of all of the different bodies that touch children's behavioral health, but an aspect of it, when we did the fiscal mapping and each state department looked at it from the framework of what are we contributing towards children's behavioral health, a picture emerged that there are aspects of each of small parts of the children's behavioral health system. And so the point you make is really well taken, is how do we look at each part of it and how does that all pull together and that we don't work at cross purposes. So one of the recommendations that came from our original fiscal mapping was we have information about state dollars that, you know, Medicaid, what reimbursement is through grant funding. We need to have the same information of the commercial insurance because that is part of our children's behavioral health system that some of these other advisory bodies don't touch upon. So that was something that was a recommendation that would have been, you know, next steps of fiscal mapping. As we did the work of fiscal mapping, what we realized is that each department understands levels of care a little bit differently. And so as the first work we did with the fiscal map is we then went back and defined, what do we mean by a level of care? What counts as a behavioral health expense versus something else? So for example, if a children whose service is being paid for by DDS, because there's a behavioral outburst, but it turns out to be, this was an example, it was a dental incident, that's not behavioral health. But actually that assessment was because the child's behavior, it turned out there was a dental condition, but we had to have similar language to understand. That's just like a small example. It's not the big picture. But where we really want to work with you is we have a map of what the children's behavioral health system levels of care, where there are needs, what the workforce, what are our strengths of our system. And now it's like as you're collecting information, how can you build upon the tools that we've already put a lot of energy in so that we can get to the next step? Because as we're doing this work, things are unraveling. And that's really the challenging part of the work, is as we're moving forward, then something is happening over here. So I think we've been working with the different bodies to say, please identify from the framework and from the focus that you have, what are the most important things right now? What are you seeing? How do you continue to work on that? And what do we bring into our group? So we have the big picture, the two groups, and then we have to pull in that information for the different aspects of it and coordinate together.
I really appreciate, I'm sorry, Ann, did you want to speak first? Okay, I really appreciate the concept of the fiscal mapping, and I wanted to say that that is something that we actually are working on right now. We've got it in the pipeline, it's being developed, and certainly it's something that we need to build on the work that you've already done when we start looking at this with the consultant that we're working with. Also wanted to mention on the peer-to-peer piece, we've already identified at least one group we are going to be speaking with on the issue of peer-to-peer and how that can further our goals in providing children's behavioral health. So I think, to your point, we do have a lot of overlap in how we're looking at the space and how we're trying to identify next steps forward. So I appreciate the hearing that we are so closely aligned in that way. Sorry, Ann, you wanted to speak?
I did. We were talking about a lot of the different agencies that impact in the children's behavioral health arena. And I would be remiss if I did not point out, we're AFCAMP, we do special education advocacy, and looking at the education system and the impact that children's behavioral health and mental health issues are having right now in the aftermath of the pandemic is very, very critical. And so we need to be, in some ways, expanding our perception of where the challenges to children's behavioral health rest, and recognize, I think as Jean Milstein also pointed out, is our children don't exist in a vacuum. They don't get into the children's behavioral health system without usually having some challenge in either the family or as individuals in some other setting, community setting, school setting, housing setting, um, food insecurity, and low income. We look at Alice data that is expanding the amount of families that are falling into that category. So with that, it's just as we're looking, we also need to expand our vision to make sure that we are seeing where those children and families are and making sure that we're hearing from them, because he who lives it knows it. They know what they are experiencing. And in many cases, they know what they need. And sometimes they know what they need better than trained clinicians and policymakers and program designers can, which is not in any way to be detrimental to them, but to understand that the voice of those that we are serving in that system have to be included in the development of that system and understand that the system changes, it morphs. I have an analogy that I sometimes think of, especially when we're doing this grant. And it's when I look at our children's behavioral health system, I think about that. There was that toy Jenga. It had like all of the different blocks in it and all of the pieces that you needed to move. And your challenge was to move your piece without tumbling the entire tower. That is our challenge, because if we move one piece of our Connecticut children's behavioral system, there will be ramifications in other areas of the system, and we need to be able to take a look and anticipate what those are going to be before we make the move. But we have to make moves because our children and families, they need us. And what's happening to that tower is, without moving the pieces, it's crumbling anyway.
Thank you. First of all, I want to thank you for your presentation also. And I think you all bring up great points about how we have a wide variety of people that are participating in all of the organizations. The one thing that I will say that TCB brings to the table, though, which is really critical, and I think I'm hoping that it's going to really help move the agenda along, is the legislature. We have to think about the fact that we have 3 branches of government that we have to communicate with, and we have to share those things so in order for us to really get the transactions done and to move it through. So it's good that we bring legislators to your voices to help elevate the issues that you're talking about, and also with the fact that the legislature is responsible for doing the budget, it helps to elevate that part too, because then we have the opportunities of addressing the needs that have been identified more clearly and making sure that it comes out. As I listen to some of the discussions and everything, I don't think that we should be afraid of having some redundancy, because sometimes redundancy does help to magnify the issues going forward. Sometimes that's a positive. It makes sure, but it's important that we communicate with each other at all times and we talk about the specific issues. Case in point, school-based health clinics. I mean, we know that that delivers a major component for our children in mental health, because that's where they get their first contacts of any types. So we bring that kind of support and connection in with the legislative members that you have participating in TCB, but it's also going through the appropriations, and you have the appropriations being represented by your chairs. So therefore, I think it's the best thing that could happen right now in making sure that as we go through these tough financial times, because let's be honest, Connecticut is a blue state, and so we have a target. So we need to remember that. this spring is probably not going to be a comfortable situation for mostly any of us as far as funding from Washington is concerned. So we need to pay attention to that and figure out how do we share whatever we got so that we can continue doing the great work that everybody's doing here today. So thank you.
And I would just like to say one other thing, just to remind people who may be listening in. Um, TCB came about after and the uptick that we were seeing around children's behavioral health issues after the pandemic, and there was a huge shift in public knowledge around this. I think many people knew about what was happening internally, but the public and was starting to see more of an impact. The schools were seeing more of an impact, and we wanted to see what we could do from a policy perspective. But there was a lot of input into how we developed this body. If there was this wasn't something that just came up willy-nilly. Understanding that there were many bodies there, and certainly there is an importance around collaboration, but that is important to kind of understand where we started. It was in response, and we wanted to see what we could do from a policy perspective, being able to have a little bit of a different leverage point. And working collaboratively is going to be our best bet because we all care about the same thing. And one of the things we did, we even did earlier this week, was looking at the schools because every school can't afford a school-based health clinic. We will not be able to afford that, and every school won't need that. So we are looking at different types of programs, and we saw a really great one this week. But I was struck by the fact that this school, this middle school, outside of this specialized program, has one social worker in a middle school in a time like this. So it's really good to see and hear what's happening. And so we really do try to immerse ourselves. People come to us, we go out to them. We're trying to learn and understand, and along with having lived experience. And it will help us to all get together and figure out what is the best way, because at the end of the day, our children are really struggling. We're still seeing the upticks, and you're right. We have a lot of difficult challenges ahead. So we're going to have to be creative in how we do this. But I just want to make sure we're aware of why we are TCB. I think it's really important to keep that in mind.
Commissioner.
I would be remiss if I didn't take the opportunity to thank you all for your presentation and more importantly for your work for all these years. And thinking back, I remember when Sandy Hook happened, and I remember Connecticut's response to and the nation's response to what happened in Sandy Hook. And you should be very, very proud of yourself for the work that you've done to date. And I'm so very appreciative of the comments that were made by all of the chairs in terms of, sort of the nuances and how post-pandemic things are different and TCB sort of stood up. I was struck, Carl, by your comment where you said you feel like you need somebody to host the party. From where I sit, I feel like in the neighborhood of people who really care about children's behavioral health, but there are several houses having parties, and so you have to go to this house to get this, and you have to go to another house to get and it's a good problem to have because we all care. I do also want to call out the comments that were made from the chairs, and particularly Claudio and Secretary Undersecretary Claudio's remark that sort of doing inventory on what is duplicative and where the spaces are, because what you don't want is to valuable time being spent at multiple houses, right? And then that impacts the workforce, the amount of labor that actually happens to produce reports for the different houses, so on and so forth. So I just really appreciate and respect this conversation. I also wanted to also call out what Dr. Ann Smith said about grassroots organizations and non-traditional approaches to helping our kids and our families. Jeannie Milstein, I just had a conversation with her about a program that she had, and sometimes the secret sauce is not in necessarily the traditional approach to therapy. Sometimes, an art program or a music program can reach our kids in a different and more effective way than our traditional sort of evidence-based, approaches to therapy and to work. So we have to all put our collective minds together, um, address this workforce challenge that we're having in a real way, and avoid duplicative efforts because it's taxing on the agencies. It's creating too many meetings, um, and we're all in the same. We're all wanting the same thing, but it involves meetings like this and opportunities like this to put our heads together to figure out a plan that works for our state. By the way, which is not perfect, and I can tell you, I've said pretty publicly on a lot of different fronts. I've had personal experience with a child with mental health trying to access the services. So you're talking about somebody with lived expertise here. And I would still put Connecticut's system up against any system in the United States. So we should all be proud of ourselves.
Thank you so much, Commissioner. If there are no other questions or comments, we'd like to thank the three of you for coming forward today. We look forward to continued collaboration, and thank you for all of your hard work. Thank you.
Thank you. Just one quick few seconds here to transition to our next presenter. As mentioned earlier, we have a guest from the Stanford Youth Mental Health Alliance, Jody Bishop Pullen, Director of Health and Human Services, and Vin Tufo, Director of Vita Health and Wellness Center. And I believe, Vin, are you online? I just want to
I am. Thank you.
thank you so much, Vin, and I will give the floor to Vin. Thank you.
Hi, everyone. First of all, thank you for the invitation to speak with you today. I um, logged on a little bit earlier and was very pleased to hear a lot of the recommendations that had come out of the advisory board, many of which are very much in line with what we're doing in Stanford as the Stanford Youth Mental Health Alliance. Before we get to this slide, maybe we can just go back because I don't want you to be reading this while we're kind of doing this part of the introduction to set the stage. Jody Bishop Pullen, who's with you today, she's going to be doing the bulk of the presentation, is our Director of Health and Human Resources for the City of Stanford, our health director. But Jody comes from public health background, and a lot of what we do in the Youth Mental Health Alliance really uses public health as a strategy and as a framework for the way in which we address youth mental health challenges, behavioral health challenges. As was stated, I'm the director of the Vita Health and Wellness Partnership. Now, this organization, some of you have heard about it, is about it's a network of human service providers that serve the residents of the city of Stanford. It consists of over 50 organizations and about 150 individuals that have been together as a network, exchanging information, building relationships, and taking on complex challenges for the last 15 years. And VITA is the backbone organization for the Stanford Youth Mental Health Alliance. My other role, by the way, and again, listening to many of the other comments, is as the housing provider for the city of Stanford. I run Charter of Communities, which is the housing authority and community development agency for the city. So certainly the implications of stable, safe, and affordable housing is very well known to us as well as to other members of the Youth Mental Health Alliance. So a lot of what we're going to be talking about today, number one, is going to sound very familiar to you because it dovetails with some of the recommendations that you've heard. It acknowledges certainly the resource and the labor constraints that have been talked about more than once in this meeting, but also highlights the importance of family and peer support for the way in which we address mental health in Stanford, which you'll hear about in detail with some of the recommendations and the actions that we've taken. But it also, as you'll see, is a very proactive approach to dealing with mental health, not a reactive approach entirely, which is the traditional approach to dealing with mental health upon detecting a condition or upon receiving a diagnosis, of course. So the last thing in terms of the introduction is that Stanford Youth Mental Health Alliance is clearly a local initiative. It's a local multi-partner initiative. Even though you're formulating and recommending policies that are at a statewide level, and you're looking for solutions in some cases at a statewide level, all action, remember, is local. And you've even cited some of those local examples in your other statements leading up to this. So with that, we'll go to this slide. Okay, great. And so the Youth Mental Health Alliance came together at the time that was just spoken about, which was at the tail end of the COVID pandemic, at the end of 2021. But specifically, the trigger for it, I think was very much, and Jody can speak to this as well, was when kids started returning to school in person. Prior to that, there was a mix of hybrid learning, part-time with in-person and part-time virtual learning. But in the fall of 2021, essentially our schools were again open for business, and kids came back to school with issues that were perhaps already seeded prior to the COVID pandemic, but were, if you will, manifesting in far greater numbers, erupting, if you will, with evidence of the personal and social isolation that many of them had experienced. Our care providers within the schools, and we have a robust system of school-based health centers in the city of Stamford. In the Stamford Public Schools have over 40 social workers, probably closer to 45 now, as well as psychologists and counselors, school nurses. But essentially, they came to the city and to the health department and to VITA and said, we have to do something more. We need something that will help to address this at scale because we're not able to keep up. We're not able to keep up with the needs of the kids, and certainly we're not able to keep up with some of the challenges that are being presented in a school environment, in class, in the hallways, on the playing fields, and in the bathrooms. So that's when we really kind of snapped into action. When we say that we have 36 or so youth-serving Stanford organizations, I want to tell you who those organizations are, sort of generically. One is that we have every clinical provider in the city of Stanford: Stanford Hospital, Child Guidance Center, Family Centers, Kids in Crisis, many of the organizations that you're familiar with because they have statewide reputations. But we also have youth-serving organizations and youth peer organizations, which Stanford is very fortunate to have. One peer organization is embedded within the school system, another is embedded within the community, and those youth peers are not only our advisors, but in many ways the if you will, symbolic client for the work that we do in the Mental Health Alliance. We have all of our educational providers. We have multiple faith organizations, including our Interfaith Council, a variety of community and social service organizations, and every government agency that interfaces with kids' needs. So if you haven't already read what's on the bottom part of the screen, I'll quickly read it because it's important. This is our purpose statement, which was created 3 years ago and is still very much holding, if you will, holding water. And that collaborative approach to the Youth Mental Health Alliance is to address the burgeoning youth mental health crisis through a community-based strategy and a response with an emphasis on promotion of wellness, prevention, early intervention, and targeted services and care coordination. So if you unpack that statement, what it really says is, first of all, we need to work within the existing youth mental health infrastructure. We need to work with the resource constraints. We need to work with the low reimbursement rates that providers are getting or refusing to accept. And we certainly need to work with our labor shortages, which results in long waiting lists. But those are the challenges, and we have to find solutions for those challenges. Creating a collaborative initiative, the Alliance, was really, really important to us. And this is something that VITA had a long experience with, because we know that when we put our, let's say, our work together, when we focus on a very clear sense of purpose and a clear target and urgency, that we can dissolve silos between organizations that are ordinarily somewhat competitive, and we can also reduce overlap and unnecessary redundancy. Most importantly, and what you'll be hearing from Jody in terms of the way we are structured and the examples of the work that we do, is that we feel it's critically important to balance clinical care, treatment, prevention, and community engagement, almost in equal measures. So we're not just simply trying to make clinical care more efficient, more available, and more, if you will, more effective. But we're also bringing together the resources and the tools and the knowledge that we do have around how to create a more preventive, more supportive, and if you will, a more resilient environment, and then how to get the community involved, whether they have a child or whether they have if you will, a responsibility towards children, let's say educators, or they just simply care about the community. So last thing that I'll say in terms of why we are why we are the way we are, why we operate the way we do, is that it's been, let's say, assumed or under or stated or at least considered that the mental health care system is dysfunctional. We don't believe that it's dysfunctional, but we believe that it's highly fragmented. And we believe that if we can reduce that fragmentation, in other words, to defragment that system and to make it less reactive, then we can bring, first of all, efficiencies into the system. We can make it operate better and more effectively, but we also can develop and assign roles to others in the community so that others can come in off the sidelines and address and help to address the mental health needs of our kids. Peers, as has been spoken about here quite a bit, families and caregivers, teachers, coaches, ministers, we feel that they all have a very clear and defined role to help to support the mental health of our children. And you'll be hearing about, as I said, some of those means and methods a little bit later. Next slide, please. So who do we serve? What is Stanford? So Stanford is the second largest and the fastest growing city in the state of Connecticut, but it's also a highly diverse city. I've been working in Stanford for over 30 years, and it has gotten increasingly diverse. And many of you know that we have a highly socioeconomically diverse population consisting of 52% of the residents being people of color, with 32% of them being foreign born, in many cases, very recent immigrants. The numbers of our children, however, are even higher as minority students. We have over 40% of the student population, in other words, the youth population in Stanford, as being foreign born, with many, many languages spoken within our schools, certainly with our families and community settings. So what we do in Stanford, we feel that we're a very progressive community, but that we are also a very welcoming community. But of course, that brings with it certain challenges, especially around the mental health and wellness of our kids. And that's kind of how we designed and how we're approaching the way in which we want to help support that mental health for our kids, so that there's really an opportunity for everyone and a role for everyone. So with that, I'll turn it over to Jody, who I'm hoping is at the microphone and can take you through most of the rest of the presentation.
In terms of started and who we represent and where we're going. It was clear to me when we started that we had to actually do something. We couldn't just talk about it. And that it had been talked about before, and we needed to really actually do something this time. So when we came together, we organized ourselves in, we have very clear goals and objectives. You heard the purpose. We have clear goals and objectives. We have an organizational model that includes 3 primary work groups: mental wellness, continuum of care, and communication. The mental wellness work group focuses on prevention, that sort of upstream approach to both strengthening protective factors and reducing risk factors. The continuum of care is looking to identify gaps in services, what are the barriers to care, and what the underutilized supports, and then look at the need for additional services. And in communications, we realize that there's stigma around mental health. We want to reduce that stigma, that it is not my concern, it's someone else's concern, and understand that it is our community's concern, and we have a community response to this urgent public health issue. In the mental wellness, some of the accomplishments that they've made is to improve the ability of youth serving organizations and professionals to interact and support children. And we do that through training and networking. We conduct free quarterly training on, with a variety of topics: social emotional learning, other topics around mental health and social media and trauma. And then the other thing is to provide for the needs of caregivers, professionals, and others to learn about youth mental health challenges, what are the early indicators, and what prevention can be done, and then build those skills. To that end, we offer free mental health first aid trainings for the community, as well as suicide prevention trainings and question, persuade, refer, which is QPR, and we can do it in multiple languages. We developed a native language speaker piece to this so that we could reach more of our population. In continuum of care, the first thing we heard from our residents was that we don't know what to do. We don't know where to go. We don't know who to call. We don't know how we can get help for our children or ourselves. So we developed a resource guide. I'll talk a little bit more about that in a minute, but at first it was a comprehensive guide with all city services and all ages, and we narrowed it down to focus just on youth with the Youth Mental Health Alliance branding. That also is available in multiple languages, and we have it in digital and print formats. And then someone mentioned that kids receive a lot of primary mental health care in school settings. So we are collaborating with the Stanford Public Schools to improve their clinical school services and also their affiliated mental health partners. A lot of the partners are able to come into the school and provide support, and they're just looking at how that all can happen together, and everybody's doing the same things. And then around communication, we have a very robust social media and advertising and public relations campaign using some professional people to help guide that work. We are out in the community a lot. Every time there's events, there's health fairs and other types of places where our residents are gathering, our families are gathering. We have member agencies that are able to have staff there with our information available. So I talked a little bit already about the resource guide. We did narrow it down so it's youth focused. It's available in multiple languages, and we have posters and the guides available in different areas of the city, including pediatric offices. When we came together to do this communications campaign and the branding around it, the message that was decided upon was, don't carry this alone, we've got you. We meaning our community. And that was very important to us. And actually we had input from the youth on that. They really liked that kind of catchy, we've got you. So that was important that their voice was heard in that whole campaign. And then over the summer, we did a web refresh and made sure it was very user-friendly, more public outward facing, and that it was consistent with everything we have going out. And then just, having available on there all kinds of resources and videos and information. We also, through our social media presence, which is pretty robust, we wanted to identify certain times when youth might be struggling a bit more. One of those examples here is the back to school time, when kids are, having a new teacher, new friends, new school, new academic challenges, and, showing support around that time. And then we know that we need to evaluate our work. So we have a group that has some of those evaluation and data analysis skills. The first thing we're looking at is our trainings and seeing who we're reaching, how we're doing, how satisfied are folks with those trainings. And you'll see some of that data here. And one thing of note in this demographic data or participant data is that we weren't reaching parents and caregivers, at least not who are identifying themselves in this round. So we are really in the midst of doing an intense focused outreach to parents to find out how we can better serve them in this area, what the barriers are to getting to trainings, and how we can support them. And then the demographics again are fairly representative of the city, so that's good to know. Um, Something else we decided early on was that we wanted to have a post-vention team. There were some occurrences in other districts that made it obvious to us that we all needed to know how to support our residents at a time when something might happen, focused on death by suicide or an untimely death. So we came together again as a team. I lead the team with a lot of support from the Stamford Police Department Behavioral Health Unit because they often have the first knowledge of some of the events. And we provide assistance to the public, to our residents who might be impacted by these deaths. And if it's a case of suicide, we can get some messaging out around that and working with our partners on all of that. It's one of those things where it's not just the school having to figure it out themselves. It's not just a faith-based organization trying to figure it out themselves. They call us and we put our team together and say, I can go, we can, we can do what you need us to do. And the data here is has changed a little bit just recently. We've actually responded to 21 cases this year so far in 2024. 4 of them were death by suicide. There were 2 recent deaths. And I'll say a couple of things about this is um, uh, they have particularly been adults, but we know that adults have families, they have workplaces, they may be prominent in the community. So we want to make sure those youth are supported. So we get out that, kind of do that outreach to make sure our team knows that either they may need to respond or they'll offer in terms of how they can respond, particularly if it's related to school children. And then the other one was a death of a youth who was in another town. So we learned in COVID, there's no walls between our towns. Kids know each other. They play together on sports. They're on social media. So it's really important that if there's something happens in one place that we all are aware so that we can support our youth and in terms of, what they're feeling at that time. Some of the more and more towns are getting post-vention teams now, so we're doing a little bit more talking to each other so that we know, who to call if you have an incident and you think someone in another town needs to know. Also, we want to make sure we are, I know we can do this because I know our city can rise to any occasion, but if there was an incident of mass casualty that we had to respond to, that we are prepared for that. Okay, so then I think this is back to you.
Yes, I'll finish up, Jody. Thank you with our last slide. And I know we went through some of this stuff pretty quickly, and we're probably running behind schedule, so I'm not sure we have a lot of time for questions, but certainly would love to take your questions now or offline at any point. You have the slide deck in your packet that was accompany the meeting invitation. So I'll finish with this. Where do we go from here? As you heard, we have a tremendous amount of support and alignment around our various providers that are part of the Youth Mental Health Alliance. And I would say that one of the reasons why we feel that the work that we're doing is in line with the needs as they understand them of the community is because every member of the Alliance participates in one or more work groups, so that the work groups themselves are populated by the practitioners and those that are really on the front lines in our community. But one stumbling block that we keep coming back to, and I didn't hear this in the advisory board recommendations, I apologize, but it may be there somewhere, is what do we do to improve the continuity of care? It's not just getting someone access to, let's say, their first caregiver, a counselor, a social worker, a psychologist, a psychiatrist, or even going to the emergency room in an acute condition, a crisis. But what do we do to ensure that that child is going to receive care all the way down the line? And one example, which some of you may be very familiar with, is when a child is in crisis, threatening suicide or has threatened suicide, let's say, is that it's the child is normally taken to in an ambulance in some cases to the emergency room, but the um, let's say the referral or the transition from that form of crisis intervention or stabilization to the next level of care, a step down or a step up in the case of child going to inpatient care or to an intensive outpatient treatment program, is very undeveloped. There's very little contact between emergency room physicians, many of whom are not psychologists and psychiatrists, and where that child will go. In many cases, a child goes back home with medication in some cases because there is not a bed available, or there's not a placement in an intensive outpatient care available, or there's just simply not a counselor that's available that can take the insurance or is available in a short term. So what we're trying to do is to learn more about what we can do to improve that level of continuity, that referral, that handoff, if you will, so that the child and the parents and those who really are very much sort of um, challenged by the situation that they're in at this point, don't really feel that they're going from one provider to another with gaps in between. So one of the things that we've done is to work with the pediatricians within our local network, and there are over 100 pediatricians in Stanford that we're working with to improve their ability to detect and provide early detection services for youth mental health challenges. Most pediatricians, as you know, do not receive any pediatric psychiatry training as part of their residency in pediatrics. And this is something you may not know, that what we're told is that 30% of the questions that kids and parents come in asking in primary care visits for pediatricians have to do with mental health issues. And so what we've done is we've partnered the pediatricians that are in the network of Stanford Hospital, Stanford Health, with our another partner, Silver Hill Hospital, that has specific expertise in in youth psychiatry to provide continuing education, professional development education, grand rounds, and a variety of other modalities so that we can help those pediatricians learn more and become more astute and better able to answer those questions that they're faced with, as well as to provide that level of follow-up care and referrals. So that's one of the areas that we're working in. This is going to be a long process because, again, it's somewhat resource dependent, but we feel that there are low-hanging fruit and certainly the ability to help to improve the continuity of care across all modalities for the kids in Stanford that are facing mental health challenges. So that's our presentation. We're very, very happy to answer any questions or to have any discussion with you. But as I said, we're very well aware also that your meeting is running over, so we understand if you need to take some of this offline. Thank you very much.
Well, thank you so much. Jody, I just want for everyone to know, it says that you are the Director of Health and Human Services, and that's for the city of Stanford, correct?
That's correct.
Yeah. So I wanted everyone to know that. Also, I have a couple of questions, which is probably too much for the time frame that we have, but I know that you spoke about why it came together, but how did it come together? As a community, how did people make that happen? The second question is this a replicable model across other towns in Connecticut? And the most important question always is on funding and how is this work funded? But I know those are big questions. They probably are going to take too much time. I'm wondering maybe if we could get a quick answer on the how were you
Yeah.
able to bring it all
Mhm.
together?
Yeah.
And then maybe we could get some feedback from you in writing on replicability and also funding.
Okay. Yes, it came together. I was approached by the chair of the Health Commission to attend a meeting. She had brought some community providers together with the Stanford Public Schools and to discuss it. And as we had the discussion, many of those folks had been in these kinds of rooms before, hence that we have to do something this time, not just talk about it. They said, well, we are all part of VITA, Health and Wellness Partnership. Maybe we could start there. And so I talked to Vin, and he had done some work with Stanford Public Schools years prior in this area, was very familiar with the work, and was on board. So his expertise and having that agency, that partnership that already knew how to bring partners together, our work as the department and working with all of those partners through the pandemic and in other areas of public health, we just were able to do that. And then just again, because we just set it up, who can who would like sort of identifying the work groups, who the chairs are, laying out the goals and objectives, getting everyone's feedback. It was a small group to begin with. We also had the mayor behind us. So the mayor had heard this through her transition, that mental health was a primary problem. It was identified in our community health needs assessment. It was a kind of a cry from the community. So there just was, I think, with some good leadership in those, from all of us, we were able to do it.
Thank you so much. And then, having been a part of that provider community, I do know that there is an enormous amount of interactivity and trust that already exists among the provider community. So I'm sure that that facilitated it. I see Representative McCarthy online. I'm sorry, oh wait, who is it? Oh, McCarthy Vahey. Nice to see you.
So much, Senator Marr, and thank you to all who are participating today. What exciting work you're doing in Stamford. And as someone who is involved in Fairfield's local prevention council, and we overlap with a lot of the kind of work that you do, I'm wondering if one of the groups who is part of your coalition is your designated local prevention council, and do you work together? And I see Vin's head nodding on the Zoom. But it strikes me that sometimes we don't always know. I know that seems you all are aware, but the work that, for example, our regional prevention partnership agencies, our regional behavioral health action organizations in our area, it's Catalyst, CT, or the Hub.
Yes.
But I'll just let you answer that question. Thank you.
Sure. Well, this is an easy one because, like a lot of things, and this goes to Senator Marr's question too, it comes down to people. And we are very fortunate in Stanford to have a very long-term member of our care community who's also the co-chair of our local prevention council. That's Ingrid Gillespie, and she works with the Liberation Programs, which is one of our partners. But Ingrid is really the, if you will, the guiding light for the work that we do that is focused on prevention and engagement of the community and the providers. So I would say through Ingrid, we are very closely related to the local prevention council.
Thank you so much for that answer, and thanks to Ingrid and all of you for everything you're doing. Thank you, Madam Chair.
Thank you. Commissioner?
Thank you. I just wanted to highlight, first of all, I want to thank Jody and Vincent for the presentation, but just to highlight that we have 59 local health departments and districts, and Stamford being represented by Jody for the local public health. And health and human services, is defined differently depending on where you are. At the state level, we're a number of different commissioners and different departments, but this is being run through the health department, the group that collaborates with us and that we work with on a regular basis. And so again, having that public health approach and the fact that, you have obviously the intervention and the providers, but you've got the prevention and the communications, which is a lot of time is what's in our bucket as the health department at the state level.
Right.
It's great to see all that you're doing and really appreciate, leveraging the levers that you have and the collaborations that you all have made to be able to do your work locally. And, often when we talk with our federal partners, they'll say, well, we know that all the work is actually happening at the state level. And, I often will say, well, actually, we are often coordinators, but they're happening at the local level. And so I think it's a great example of what you've been able to do in Stamford. So thank you for that.
Thank you.
Thank you.
Okay, thank you so
Thank you.
much. I hope that maybe we can talk offline about the other questions.
Sure.
In the
Okay.
future.
All
Okay.
right. Thank you for having us.
Thank you for
Appreciate it.
being here.
Thank you very much.
Thank you. We have one more presentation, and that is an update on the ICAPS Intensive In-Home Child and Adolescent Psychiatric Services. Sorry, just realized I said the whole thing. But want to invite, yes, Victoria over to give her the floor. And you do have these slides also, and all of these slides in your package, just so that you're aware.
Great. Hello, my name is Victoria, and I'm the clinical director of ICAPS Model Development at the Yale Child Study Center. And thank you for having me back. I have some updated data for you, and I think some really promising results following Medicaid investment in the program and DCF supplemental grant funding. Thanks. So just kind of to situate everyone, ICAPS is a attachment-based and multi-generational complex trauma-informed treatment model. It is offered to children and families who are in acute psychiatric crisis. It's a 2-member team who goes out to the home and does parent, child, and family work. It's very intensive, so folks are receiving 4 to 6 hours of therapy every week. Teams also provide kind of wraparound support in 4 domains: child, family, school, and community. So I've kind of put on this presentation, this one-pager, data from the last fiscal year. And as you can see, kind of some interesting patterns or changes when we're looking at the demographics of the kids in the program. We have about 12% who are this kind of 3 to 6 age range, and we've seen that growing since the pandemic. When we look at comparably pre-pandemic, and then we have a period during the pandemic and kind of now. Additionally, our bread and butter is kind of this 10 to 15 age range, but we're seeing more of the 7 to 9-year-olds as well. And we also see kids that are kind of exiting the mental health system at the kind of 16 plus range. Of note, I think we have kind of gender data now, which is really interesting. And we are seeing that in ICAPS, we see about 5% transgender and gender nonconforming kids, which is a really high number when you look at kind of what state level data we have. Most of that is looking at the 13 to 15-year-olds, and it's under 2%. So we're seeing like we really disproportionately see a lot of kids who are trans and non-binary, often likely kind of struggling with social stigma and rejecting family systems. So family work is really indicated here. Our outcomes are in the last year are really great. I think most of them are pretty consistent. The decrease in hospitalization days is probably our highest number, which is 72%. And so that's when we look at the amount of time kids have spent in the hospital 6 months before they do ICAPS, and then during their 6 months ICAPS. And so we see significant cost savings for the state there. There's also a graphic up there about diagnoses, and you will see that we kind of, and so this is just primary diagnoses. Most of the kids in the program have secondary, and many have even 3 or 4 diagnoses. So we see a lot of disruptive behavior kind of disorders. So that is ADHD, DMDD, kind of the more externalizing aggressive. And then we just see a huge percentage of mood disorders. And both of those are often coupled with trauma. We know when we look at our parent population that over half have endorsed 4 or more adverse childhood experiences. And so we see a lot of that kind of playing out in the parent-child dynamic. I will go to the next page unless there are any questions here. So we are primarily Medicaid funded, some private insurance, but really mostly Medicaid. The percentage is under 7% of non-Medicaid. And our training apparatus and our quality assurance apparatus is funded through the Department of Children and Families. Update on the network post the Medicaid rate increase and the supplemental grants. So we had 2 sites that were at risk of leaving stay in network, and they've been able to staff up, which is really promising. We have been beginning to kind of receive contracts from DCF with the supplemental grant funding and working with kind of clarity around what those can be used towards. Post-pandemic, ICAPS was seeing around 2,000 kids per year, sometimes over that even. During the pandemic, that went down to around 900, and we're back up to about 1,300 in the last fiscal year. And I think that's largely because of a lot of the work that was done here. I think that's what I have. If there are any questions. Our wait list continues to be very long. It's 546. Families tend to wait for the service because there's not really comparable service. Most outpatient clinics do not have capacity to offer much parent or family level support just due to the high volume of cases. So this is something kind of specific that we offer in our program that's difficult to find elsewhere.
Thank you so much, Victoria. Rep Walker?
Yeah, thank you for your presentation. How does one get referral to ICAPS?
You know, we've looked at where our referrals come from, and they really just come from all over. Many come from the hospital or the ED. Many come from IOPs, where kids are kind of going in the intermediary time. But we also do get referrals from DCF. We get referrals from juvenile justice. We get many from schools. And then we'll get parent referrals, people referring themselves because they're really struggling with. Usually those are cases where children are kind of not getting up, not getting out of bed, like the depression is so chronic, but there's not an acute crisis that's bringing them to the emergency room.
So you get referrals from schools too?
Oh,
right?
absolutely,
Yeah.
yes.
And in those circumstances, when a child is referred from school, are there criteria in order for them to do that? Or if they just feel this child is out of control or whatever?
So there has to be, you have to show that there's been acuity and that there've been other attempts made, right? So if it was a school trying to refer right to ICAPS and there's never been outpatient, there's never been IOP, most of the time we're gonna ask a family to seek out one of those things. Problem is many of those are not immediately available, and then the problem worsens, making it really requiring an ICAPS level of care.
And what's the average time for you to, let's say, I have a child that's acting out in school. What's the average time for, or wherever, what's the average time for me to get actually connected to a clinician?
In ICAPS right
Yes,
now, so it
yes.
depends on where you're at in the state, and that about half of the state is not receiving services. We don't have any coverage for New London or for kind of the quiet corner.
For Senator Olson.
Yes.
Her side of the
Her side
state.
of the, exactly.
Yeah, I just.
Right now it's about 4 to 5 months.
4 to 5 months before I get seen by a clinician.
Yeah.
Wow. And is it because workforce?
Well, workforce, I will say it has stabilized in some places, and I think that has a lot to do with salaries being adjusted following the Medicaid rate reimbursement increase. It's capacity, yeah. So we don't have enough sites. We probably don't have enough teams to meet the need. We also don't have good step down. It's really intense, a lot of support. And to go from that just to outpatient is very difficult for families, particularly because the program really focuses a lot on parent support and family support and co-regulation. And often that is something that's really compromised.
Yeah, that's what I thought. And when you said your team, you have how many members of your team?
Like an ICAPS team or
Yes, ICAPS team.
two.
Two. Okay. And let's an average cost for one for a visit. I mean, for a for a referral or something like that.
Average cost? Oh gosh, I would refer to someone who works at one of the clinics that runs the program. I don't know if I'm sure I can get you that number. And I think I've even heard this number before, but I can't recall it off the top of my head.
I've heard it, but I just just wanted to know.
Yeah.
No, I mean, ICAPS is probably one of the more preferable, especially when there are serious issues with the child. It is expensive, and so because of that expense, I think that's also why we don't have as many engaged clinicians in that, because it's very hard to fund. But thank you for your work. I know it's hard, and I'm really impressed with the numbers though. When the 70,
so I would say that it's the
72%.
cost savings make the price of the program worth it, and it's
Oh.
really difficult to provide a whole family with support with a single clinician.
Yeah. Well, no, I mean, any child we save is worth the expense. Yeah. Just have to help explain that to some of the people. But thank you very
Absolutely.
much for that information. Thank you.
Yes,
Thank you for your service.
Thank you.
And I'd just like to say, you know, I am a big supporter of ICAPS. I've seen ICAPS and understand how it works, and that parent piece, that continuity, it really matters, because the whole family, a child doesn't have an issue alone. They're attached to the family dynamic. It impacts the family dynamic, and having individuals go into the home. I do think that in the ideal world, there would be a way to tap into it. The commercial side is low, but children with commercial insurance are also having these issues, and it can be very, very difficult to tap into the ICAPS program when without knowing it exists. Sometimes it's something that you happen upon in certain cases when we're looking for ways to address these issues, as you might leave a hospital setting or something like that, or make a complaint or something that eventually connects you to the program. But I think it's really good. I know this is probably out of turn, but it's something I think about because I know it's expensive. I also know it's a big commitment. It's, what is it? 20,
6 months.
it's
Yeah.
a 6-month commitment.
3 sessions a week.
Two sessions a week, right?
Yeah. Boom. 3.
Three
Yeah,
sessions?
2 to 3. Yeah.
Okay.
It's
Can it be 2 to 3?
flexible.
Okay,
right?
I thought it was flexible.
So it's
Okay.
flexible, but
Yeah, my experience was two sessions a week. So I'm curious to know if there's ever been a thought around an ICAPS light, where there may be. I'm wondering about families who may not need a 6-month, but may need a 3-month or something like that. Has there ever been anything like that?
I mean,
Evaluated?
that's something that I think we're open to discussing with our state partners. Absolutely.
Okay.
I would say that the light is certainly need, but also maybe extended for those kids who really struggle to stabilize in 6 months. I think we see both ends of that spectrum.
That makes sense.
Yeah.
That makes sense. So if there was some flexibility within that, it would just be, I'd be curious to see what that looks like. But just throwing that out there. There are other questions, that are online, and I don't want to.
Alice.
There was one question about whether or not ICAPS is available for children with intellectual disabilities.
Yeah, so we serve actually, I think, a good percentage of kids who have intellectual disability in addition to a primary psychiatric diagnosis.
So thank you very much. That was online. And now, Alice. Alice first.
Victoria, thank you so much for the presentation and for everybody's presentation. It's really informative this afternoon. I just have to ask a really dumb question, but ICAPS is not under granted, meaning it doesn't have a grant on top of the patient fee for service. Am I correct?
Correct.
Right. And so in my thought, other than the particular grant programs that are out there that are not billing Medicaid, I think in the outpatient array, ICAPS may be one of the very few programs in the Children's Behavioral Health Services that is not co-funded with a grant. And that has meaning to us, all of us, because when you're implementing a program, you need to have some funding for startup. When you're hiring a staff, they don't automatically get a full caseload. You have to orient them. And so the investment on our end as a provider is, there's a front end investment. And honestly, the rate I don't think is covering the true cost. And when I mean the true cost, I mean there's the actual salaries and benefits and things like that, and then the travel, overhead, training, things like that. So whoever's hired, and when you're doing ICAPS, you earn your salary, so to speak. You get your salary whether you earn it or not, but you have to do it by fee for service. And there's such a small amount of extra dollars in that, it becomes a real difficult for agencies to kind of start up in that. And I guess I was sort of trying to back end answer the question of why there aren't any services in Center Austin's area or in New London, because it's such a risk for an organization to do that. And so the idea would be that you would want to, if you want these services to happen in certain areas, that there should be an investment of implementation and startup that is, accounts for that and increasing the rates. And Victoria, if I misspoke, please let me know.
No, absolutely. I think that it's a little bit of a different situation for large sites that are able to have 8+ teams. I think there's a
Exactly.
financial difference where it's easier to remain afloat when you have more teams, but when you're a smaller agency or in a more isolated area and don't even kind of need to staff up to that number of teams, there's an annual kind of loss that you are struggling with, and also just the onboarding costs, like you referred to, Alice. It takes a lot of work to stand up this program. It's complex and it's pretty clinically sophisticated. There's a lot of support that goes into those kind of first 3 years of doing ICAPS.
Thank you. Before we call on other people, Victoria, thank you for your patience. I just wanted to say that we did get a comment online from Michael Patota from the Children's Guidance. I'm sorry, I can't see the whole thing. Child and Family Guidance. And the comment was enhanced care clinics, OPCCs, are bridging cases that need a higher level of care. So outpatient clinics are able to provide treatment to kids needing a higher level of care, and they're doing it currently. Michael wanted us to be sure to share that with everyone. Now, I know that we have Representative Nuccio online, and then we have how many hands? Is he 2 over here? Okay. So let's go to Representative Nuccio first, and then we'll go to the people in the room. Thank you.
Thank you very much. So I just had a question, for the 4 years that I've been up here, I've tried to learn as much as I can about ICAPS, and Tammy and I have talked about it, Representative Exum and I have talked about it quite a few times. And I know one of the big hangups here really for kind of expanding the program is the whether or not it is accepted by private insurance is the peer review in the research, the substantive research that would allow it to be paid for by private insurance companies also. Have we had much movement on that? I know when I spoke to representatives from ICAPS, they felt like, overall, they felt like that it was peer reviewed, but it hadn't actually gone through the process, which is the holdup. So I'm wondering if we can maybe get an update on where we are in the process of that and actually getting it reviewed.
Well, I guess my first reaction is that we can't even provide services for the Medicaid families that are requesting the service right now. So uh, that's not been, we've really honestly been in stabilization mode and trying to get our capacity up to where it's at, as opposed to kind of pursuing the kind of non-Medicaid private insurance. I will say in the supplemental grant funding contracts that sites are receiving from DCF, there is mention of non-Medicaid billable families. So, there's a potential way of covering that. However, given most sites' wait lists, that would be a tight time frame.
So I understand, what that it's a staffing thing and we don't have enough sites and people, et cetera. But I still think we would do well to have this program fully reviewed. So maybe we could get more grants for it, et cetera, outside of just what we have here in the state. And also to look at, again, for the ability for private insurance to have that, because it's not just kids that are on Medicaid that have these mental health issues, right? There are a lot of kids that are having these issues that may have private insurance. And I understand that it might be a capacity issue for you where you are right now, but perhaps with more people able to benefit from it, we could have expansion throughout the state and other areas to have more providers that would be able to do this kind of work. So I would just like to encourage you guys to continue down the path to make sure that this is all fully reviewed and it's acceptable as a treatment program that will be covered by private insurance also, and not just Medicaid.
Yeah, absolutely. And I see the need as well. We are in the process of applying for national evidence-based status. And that's a process that we do following publications where we're kind of doing different analysis of the population. So I'm hoping that's something that we can work towards in the next few years.
Perfect. Thank you.
Mhm.
Thank you. And thank you for coming to present. I wanted to just say I agree that with Alice that there are barriers to entry, and that's something that an investment could fix, especially now that the payment is somewhat more sustainable. And so thinking about that as a potential avenue, I wanted to second. I also wanted to kind of second the potential value of looking at more individualized length of service decisions, right? I mean, we know that not every kid needs 6 months and not some need more, some need less. I totally endorse that direction. I wanted to ask you a question about the MDO services. I see that there is some significant support coming through ARPA dollars to support the work of MDO at Yale. And I'm wondering, kind of what does sustainability look like for the work that Yale does?
Mhm. So the ARPA dollars actually didn't go to MDO. We have a contract with DCF that currently funds myself and my co-director and a data analysis person. There are a couple other like very small positions in that, but we certainly would like to be able to provide more clinical support to the network, particularly given the level of acuity that we're seeing in kids. A lot of chronic suicidality, a lot of aggression. Clinicians, teams are concerned about going into homes. And so there's a lot of support needed. Also, we have kind of a brand new database that is able to provide you with these kind of analyses that I'm referring to today that was funded entirely by a private donor, but needs ongoing enhancements. So we are kind of advocating for additional financial support in our kind of quality assurance, quality improvement, and training program.
Thank you. I just want to talk about or sort of make a comment and then I have a question, but I think the percentage of reduction in hospital admissions, inpatient stays, and emergency room visits is pretty striking. And I think speaks to the value of intensive intergenerational in-home services being available to families and children. And sort of thinking about that in the context of having 544 kids right now waiting on that wait list, and sort of what happens to them while they're waiting. And so I think it speaks to the value of investment in in-home intensive in-home community-based services. And my question is there any data that's maintained on the kids who are on the wait list in relation to emergency room visits and inpatient stays once they've been identified and accepted to ICAPS while they're in that waiting period? Is there any data that's collected so that
We
to
collect
know?
6 months prior to ICAPS, and often they've been on the wait list the whole time. Yeah, or majority of it. And so that's what the numbers here are. I will say, I think that the ED visits continue to be high during the initial period of ICAPS, often as part of the stabilization period, which is kind of our theory on why that number is less high.
Thank you. And then there was a question online about follow-up with the family, if that happens periodically after they're finished with the intervention.
Follow-up or re-referral, is that?
Follow-up. It said, what do we know about the lasting impact of ICAPS? Is there a follow-up with the family periodically post-intervention?
Thank you.
Was someone going to say something?
I'm sorry, Mickey.
No, I'm sorry. Hi, this is Mickey Kramer. That was my question. In
Great.
terms of, I think it's very encouraging on one hand that your data suggests that during the course of treatment, families do better, and folks have attested to that, et cetera. Not all families, obviously, but families in general are saying that it's helpful. Kids are feeling better. Things are going better. But I guess one of the things that I don't know that we do terribly well is really take a look at the lasting impact of some of these interventions. And I think if we were to study or be able to kind of communicate that that in fact 6 months later, a child and family were still doing well or better, it's all relative, then we can muster up more support for funding in doing well during the course of treatment is wonderful. But really what we're all looking for, I think, is for that to have a lasting impact. And ICAPS is just one service that we would want to know that about. Does that make sense?
Absolutely. So I have some data for you in response. So we did an analysis of repeaters and found that about 80% of kids don't require the service again. And for those who do, often related to kind of chronic, more acute psychiatric issues, they don't come back doing as poorly as they were the first time that they started, and they make additional gains on top of their last episode. And so that's actually a publication we have under review right now. There was also a look at ICAPS around 2010 where we did before ICAPS, during ICAPS, and 6 months after, and the gains made were found to be sustained. We're hoping to do an additional study of the program, maybe a randomized control trial of our wait list. And this would kind of, as part of that design, we would also follow 6 months post.
Thank you. That's really encouraging. I think we all need that information.
Thank you so much for the presentation.
Absolutely. And thank you for all your work stabilizing this program, sustaining it.
And I just want to add thank you for the data, because we know how incredibly important data is. And it's reassuring to hear that on a repeat user that you're seeing an increased level of capacity and a shorter time frame for the using of the services. So that's the kind of thing we're all hoping for and looking for. So thank
Yeah,
you.
and I think it fits the developmental trajectory of psychiatric issues for kids, particularly kids with complex trauma. It's not just going to be smooth sailing throughout their development.
That is absolutely what I learned in graduate school.
Yeah. Yeah. Thank you.
Okay, I think that takes us to the end. Did you want to talk
Yeah.
to updates?
Yeah, so just very quickly, a few updates. And in your packet, there is the just a timeline table about the recommendations, legislative recommendations. As you all know, we released a draft in October, and we are appropriately in the stage of massaging, revising, collecting feedback, seeing, just adjusting as appropriately. And so it is our hope. The chairs and I and my team have been meeting frequently, and it is our hope that we may be able to send out a revised draft by the end of the day on Friday. I did mark there tentatively where, there's a lot of conversations taking place. So, but that is our intent. Our goal is, and that continues to be, as you all have charged us, is that January, at the January TCB meeting, there will be a set of recommendations that this committee will be voting on. And so, to move forward with. And so there is something that will come before this committee. It's just that right now we're still in development phase of that. And I'm not sure if the chairs wanted to say anything else around that, but. No, okay. And then the other is we are looking to activate 2 work groups in the beginning of the new year. We are continuing. We've actually, thank you for some of you who have volunteered and sent in your resumes and interest for being considered as a chair for either the school-based services work group or the prevention work group. And so those are 2 work groups that we are looking to activate, and there will be interviews scheduled with the chairs of this committee, and then an appointment will be made. Lastly here, we have finalized a draft, a draft version of an orientation manual for this committee based off of all the different, how we've operationalized ourselves, just administrative tasks type of things that as new members are coming on board, and we will have probably new members being appointed at the new year due to the election results and appointmentships. But the orientation manual is just the sort of the what is, the how to, the when, how, why around the TCB work. And you can contact either Emily or myself for some feedback. And lastly, very excited to say we are moving along with the strategic plan of the TCB, which will be coming to you. We've adjusted the timeline a little bit more so that we can ensure a deliverable of recommendations for this committee. So there will be, right now we're tentatively hoping to have a full package for you on the strategic plan by the March meeting. We have just conducted several focus groups, one with the various leadership as well as state agencies, and we are scheduled to do a focus group with parents and youth. That is scheduled because we also want to make sure, just like it's been talked about here, that we hear from parents and youth. And I do want to also comment from earlier, one of the things that we have done and engaged due to some requests is that that we do hear from youth and parents. And so, and that we do have what is called, we mirrored what we do on the Juvenile Justice Policy and Oversight Committee, what's called a community expertise work group. And those are organizations that work with youth and parents directly, and they will be the ones helping us to ensure that youth and parents are at this table moving forward. And so we will be engaging. We have identified 3 organizations. They were here today on the virtual setting. Sometime in March, they will start to be in this room as well, and sort of following suit with what we do in our other committee as well, which is working very well. So just wanted to say that. And I believe that is it, other than happy holidays to all.
Happy holidays.